In this episode, we're going to talk about the best time to test for HRT levels. I'm Dr. Valorie from Progress Your Health.
And I'm Dr. Maki from Progress Your Health. So this one was submitted on our website by the little submission form we have called Ask the Doctor. This is a question from Lisa. Of course, we changed her name. I do know because she actually reached out to us a second time. She's actually a fellow Washingtonian. She actually lives in Washington. I just thought I'd throw that in there. So why don't we go ahead and read Lisa's question.
I'll read Lisa's question. Okay. So, hi there. Love your podcast. Thanks. I keep hearing differing opinions from providers on when to test serum levels. Some test peak and some test trough. Do you have a time frame of when you test serum levels when using a Trochee or a transdermal cream? Is it 4 to 6 hours after applying or 10 to 12 hours after applying? It doesn't seem like this delivery method accumulates in the serum, so testing estradiol levels too long after application levels will be so low. Do you suggest testing FSH and Estradiol together to give a patient a better idea if the estradiol is on board for long-term protection? Thanks so much.
Well, she obviously she knows a little bit about hormones because she asked some really good questions there, both timing and adding some other tests about the FSH. Most people are not really aware of an FSH. So what is your, and of course she says she loves a podcast, so thank you for that. Why don't you kind of dive in? Where would you start with this question?
Well, I definitely like to test blood work. We've been doing blood work for about 20 years. We've done saliva tests and urine tests, and there's lots of different testing. But I feel like, and I was talking to you about this a little bit earlier too, that regardless of the testing, it really comes down to, I guess you could call it sort of who's reading the test. So are you accurately able to get the information from the test that's going to give you a way to get the right dose for Lisa or changing up the dose? So I definitely do like to see how the body absorbs the estrogen and the progesterone, but it's a little different. So for example, on a static dosing, somebody might take their progesterone at night, but they don't take it in the morning. So when you do your blood test in the morning, that's like 12 hours later. But then when you put your estrogen, because a lot of times you put on your Biest or your estrogen cream, transdermal cream, twice a day, a lot of times also with a Trochee, which is a form of estrogen that you put on the inside of your cheek or kind of a little bit under your tongue to absorb sublingually, you might use that twice a day. So you definitely don't want to put on your estrogen cream or take your Trochee and just run right down to the lab to get your blood drawn, because then those levels will look a little falsely elevated. And we've seen that. I've been like, oh, did you put it on and 30 minutes later you had your blood drawn? They'll say yes. But I do think waiting 10 to 12 hours might be a little bit too long because we want to see what the absorbency is. I know after 10 to 12 hours, that level is going down, which is why we do Biest or estrogen cream twice a day. So I do like the 4 to 6 hours to see, what are your levels at? What are you absorbing?
Yeah, this is a sort of you think it'd be very black and white, like do it at this time, but I think it depends on, like you said, it depends on the dosage type. It depends on the dosage itself. It depends on the woman. Sometimes pharmacies will say to rub your cream on your forearms. We don't recommend that because if you did that and then went right to the lab, then you get these really crazy numbers. What's the highest real or fake estradiol number you've ever seen?
Like you said, I haven't had many patients put it on their arms, but I know you have. And even if they waited 6 hours and they had put it on, even 6 to 12 hours and they had put it on their arm, and then they use the needle, it comes back really high.
Yeah. I've seen a few that are like 1,200, 1,100. I've seen some really high numbers. I've seen a gentleman with testosterone, transdermal cream. His testosterone was like 4,000. And when you see a number like that, automatically you know that it's not an accurate number, so they have to go back and retest it. All right. So she says she gives a time frame, 4 to 6 hours, 10 to 12. So you're saying there's a sweet spot in there somewhere, depending on those other variables, the dosage form, the dosage type, the dosage amount, that will dictate, kind of when they should actually go to the lab, to get a good idea what their numbers are.
Yeah, exactly. And let's say she went 6 hours. It really depends on your practitioner and who's interpreting those results. So let's say she puts on her cream on the inner thigh, which is where I like to have, the transdermal creams for the estrogen applied, and then goes to the blood, gets her blood drawn maybe out 5 hours later, and it comes back at a certain number. Let's say it comes back at 65 for the estradiol level. so what would, so it needs to be interpreted. Somebody could look at that and say, is 65 too high or is 65 too low? So I think it also depends on interpreting it. And there's no real set levels. I mean, we've gone to lots of continuing education courses. We've taught this. We've been doing hormone replacement for 20 years. There's no set level of this woman needs to have her estradiol at this level, or all women need to have this. Because I have some women where maybe a 65 is too high, and some women that number is too low. So there's that you have to take that objective data of the blood work results and then pair it with that actual human.
Yeah, I haven't looked at the study, but I think it was a study out of Italy, somewhere in Europe. I want to say Italy, but it was somewhere in Europe, and they just established a estradiol serum blood level of 60 nanograms per deciliter as being sort of a protective amount, brain, bones, heart, that kind of stuff. I haven't looked at the study yet. I just heard that secondhand. I mean, if someone's doing hormone replacement, 60, I will say transdermal, it's not going to get up to 60 very easily, right?
It depends on the dose. I mean, I do think 60 is a good number, but let's say that woman feels like, oh, my bones are protected, my heart is protected, but I'm bleeding. Then that's not safe.
Yeah, right.
That's not protective.
Yeah, right. You can't have, that's why when it comes to static dosing, that's why the number being too high matters more than the number being too low. And one thing I know you and I have never done, and this is a word to everyone watching that is on hormone replacement, is we've never chased the numbers. Chasing the numbers is enough to drive you crazy because we want the lab work, and I think even doctors do this too. You want the numbers to be 100% accurate. But you've done this enough times, which you and I have looked at thousands and thousands of blood work over the years. You realize, you see some patterns, you understand there's some patterns, you understand there's some tendencies there, but you can't put too much trust and faith into each number that you see because there's so much variability. Why that is, I don't know. It's just it's the testing an estradiol level blood. You and I are the most comfortable with that. You could ask, 20 different practitioners. You're going to have a handful that say blood. You're going to have a handful that say saliva. You're going to have a handful that say urine. I think it really comes down to, like you said, it's really the practitioner interpreting it and their experience with that particular medium that they use.
And what Lisa's saying here about doing the follicle stimulating hormone or the FSH paired with the estradiol, that's what I always do. I do feel like that is a good connection because the FSH is a signal from the brain, the pituitary, which is monitoring the overall, estradiol levels in your body, whether your ovaries are secreting them or you're applying it as a transdermal cream or a trochee. It's monitoring that. And if the levels are low, you see that FSH go up. So somebody that's in menopause, you'll see an FSH level easily at 80 or higher because that ovarian function has gone down if they're not taking hormones. So when you're doing that static dosing versus the rhythmic dosing, which is a whole nother, different conversation there. But in terms of a static dosing, let's say that Lisa's doing the same biased or her trochee, the same dose every day, is that FSH is still going to look like it's in a menopausal range, but you don't want it to be super high, like over 100. So her levels, you're sort of checking like what's she absorbing in the moment. What's my hormone cream going into my bloodstream? What is my level right now? While the FSH is sort of looking at the bigger picture of what the body thinks the estrogen levels are over a long-term period. So, for example, when I did my hormone, I'm doing a rhythmic dosing. I change my things all the time, and maybe I don't know if I should be my own doctor, but
you're not a very good patient.
But on one of my blood work, my estradiol level this was the one we did in January, that my estradiol levels were in the kind of the low 100s, but I'm doing a rhythmic dosing, so that's okay. So I was on the very first part of the follicular phase, so it was before the progesterone, so it was during the estradiol. And this one was...
You did 21 first.
21, and then my estradiol level was good. It was like at 120, something like that, or 130. And my FSH was at 20. So even though on a reference range, when you're looking at a lab rec and it's giving you these reference ranges, an FSH looks like that of maybe a going into menopause, but a 20 is good. Yeah. But I wouldn't want someone on a static dosing to have an FSH at 20. That would mean that their estradiol continuously was probably a little bit too high.
Sure.
So there is a dance to balancing and getting the information and then what you're going to take away with that information.
Yeah, right. Yeah, it's and now with a transdermal static dose, like a typical biased, you're not going to see a lot of movement on the FSH. Right. The FSH is going to stay pretty much elevated. And even blood level wise, an estradiol level is going to be, again, depending on the dosage. The ones that we see from people asking questions for Ask a Doctor, they're always on relatively lower. She doesn't give a dosage here. What we've seen is a trend that they're on relatively lower dosages, 2 to 3 milligrams or less. That's not going to raise your blood level very much, right? So it doesn't, at that point, if you just put your cream on and then go to the lab, you might get a falsely elevated number. But that's more of the application timing than.
You mean like 30 minutes or
let's
an hour?
Let's say a woman just put her cream on, went right to the lab, and then now that number comes back as being 200, 250, 350. A 2 milligram or a 3 milligram bias typically is not going to create that. Yeah. So now that number is a little skewed. Where let's say someone's using a trochee or a patch. They just put their patch on and they go to the blood. They go get their blood tested. Now that number could actually be higher like that. So you sort of have to know, when that timing was and what. Obviously, if you're prescribing it, the practitioner would know all those things. But that's why there's not really one way to do that.
Yeah. So I would say, you're right. There's not one way to do it. But if you were to say, maybe collectively or as a catch-all, is yes, 4 to 6 hours later after you put on after you put on your biased cream. Like when I'll get patients' blood work, and I always look at the end or at the top, depending on what lab they went to, and find out what time it is. So if it'll say like 11:30, I can usually say, oh, they probably put it on around 7, or if it's at 3 in the afternoon, I'll know, oh, they probably put it on around 6. I can tell just by looking at that number when they probably applied it versus when it showed on that blood draw when they collected it. So I do think the 4 to 6 hours is a good mark. 10 to 12 hours ends up being a little bit longer, but that's why you have to pair their symptoms along with the numbers. Like you said, not chasing the numbers. Because I know I was chasing the numbers when I was looking at my blood work, because then I did another one recently that I wrote in my news article. I think I did, or maybe I did a video on it. But I was a little disappointed because my estrogen level was a little low, and I felt like I got a bad grade, but I feel good. I do. I feel good. So is that level low because it's showing up low? Because I think it was a little bit lower when I did it.
At least for rhythmic dosing.
For the rhythmic dosing, it was a little bit low. But I don't feel like it's low because I feel good.
Yeah,
so it's, putting that pairing together.
And at the end of the day, our approach has always been you treat the patient first, and then you use labs as a way to guide you.
Yeah.
You don't necessarily, yes, sometimes labs, depending on the situation, a lot of things in medicine where labs, decisions will be made based on lab testing. But when it comes to hormone replacement, it is, the subjective is very important. Like you said, how you feel versus what your numbers look like. And then you sort of figure out your clinical decisions based on those two pieces of information. It's not one versus the other. Now, you mentioned rhythmic dosing as what you're doing. That's where I think actually the accuracy of the testing is actually, you're going to see because the dosing is quite a bit higher, you're going to see much more, changes to that estradiol number and to the FSH, like she alludes to, where on the other more static forms, you may not, I say that in air quotes, you may not see as much change from one blood test to the next.
No, exactly. So rhythmic dosing is where you're changing the estradiol and their progesterone levels to mimic an ovarian cycle. So on a static dosing, every day you can just go in, you're doing the same dose. So for example, I was supposed to get my blood work done last week, and I totally must have messed up on that LabCorp and didn't press confirm at the very end, and I didn't have my appointment. I felt bad. So I wasn't able to get my blood drawn on day 12 because I'm on rhythmic dosing. It's not like I could go again the next day or on the 14, day 14, because my level would be different. On rhythmic dosing, day 12, that estradiol is the highest it's going to be, so I wanted to capture that. Unfortunately, I didn't. I'll catch it next month. But that's where,
unfortunate. You have to wait a whole nother 28 days to get to day 12.
And I could have. You were like, let's just go to the lab and you just drop in. But I'm too shy. And that gal that works there, she is so cool, but she is strict. Yeah. I see her with the other people. She's strict.
No, she kind of. It's a busy lab. There's a lot of people coming out. I'm sure every lab is that way.
So in the rhythmic dosing, there is particular times in that cycle that you're going to want to get your blood drawn. For progesterone would be closer to about day 21 when that's the highest, and then day 12 for the estradiol. But in the static dosing, because every day is the same, is you could do that any day. But I do feel like that 4 to 6 hour period after you or I guess that 4 to 6 hour time period after you apply that Biest would be an appropriate time to have that blood drawn. But then progesterone's a little bit different because in static dosing, most women don't take their oral progesterone in the morning because that'll make you too tired, right? You don't want to take oral progesterone in the morning because it raises up or stimulates your GABA receptors, and then you get kind of lethargic and tired, where you take your progesterone the night before. So if you took your progesterone the night before and then you went to the lab that next morning, that could be about 12 plus hours after you've taken your progesterone and then you've done your blood draw.
Yeah, one little trick, I don't know if you call it a trick or not, but one way to double check is using a transdermal estrogen, a Biest and an oral progesterone, very common. Lots of women are doing that. If a menopausal woman is not taking progesterone, her blood level of progesterone is going to be less than 1. Mm-hmm. It's going to be like 0.7, 0.5, 0.4, 0.6. If she's taking oral progesterone, like I said, even from the night before, that number is going to be greater than 1 to some extent. So it's going to be 2. What would you say? Somewhere between 2 to 8 is that you see it the most often?
I'm a little particular when it comes to the progesterone levels in the morning when you do the blood draw. So you took your progesterone the night before, you do your blood draw the next morning. I like to see that progesterone around 3.
Yeah, 3,
I think 3, if you have a uterus, is very protective. When it goes a little higher, like up to the 8s, then that's a little too much in the morning. That's why somebody might feel a little groggy in the morning, or, oh, it's hard to get out of bed, or I'm so comfortable, I can't get going. And that's because that progesterone is still a little too high in their system, stimulating the GABA receptors in their brain, making them a little bit, because in the morning we want to be bright-eyed, bushy-tailed. I got to get out the door. So in that case, I'll switch their progesterone from sustained release, because sustained release is really great for helping a woman's keeping that progesterone in your body while you're sleeping to help you stay asleep, because a lot of us ladies are notorious for waking up in the middle of the night. So if they're having no trouble sleeping, but their progesterone levels are a little higher, like around 8, I've seen 12, 14, then I'll switch that sustained release over to the instant release and try to get that number down. Now, the sticky part comes when, let's say you switch it to an instant release and it's still a little high in the morning, and they're still a little groggy in the morning. Then you say, well, I don't want to reduce your progesterone dose, because if you have a uterus, and the breast tissue, progesterone is very uterine and breast protective, is I don't want to lower that. We're already on the instant release, then I'll have them take it earlier, or we'll switch to the rhythmic dosing, which I find with the rhythmic dosing, you can really kind of balance that progesterone a little bit better to keep people from feeling groggy. So I just said a whole bunch right there. Does that make sense?
Well, see, that's why it's not a really one size fits all. There's so many nuances to it, and every woman is going to respond a little differently. And you can't ever predict, based on a blood test, you can't ever predict how a woman's going to respond to the hormones. They actually have to initiate some type of protocol, and then you iterate and change after the fact. So it takes a little bit of tweaking to get those numbers. Maybe not to get the numbers right. It takes the tweaking to get them to feel right. Mm-hmm. Okay, because the numbers, now one thing about timing we didn't mention, this is about HRT, but I will say the timing you were referring to, the 4 to 6 hours, that really, and I do the same thing. You look at the lab test and you see what time the lab was taken, because that really is a bigger deal when it comes to their thyroid dosing. Right.
Oh,
the close
thyroid dosing. Yeah, exactly. That's the same concept here too.
Yeah, you take a thyroid dose, your body absorbs it. Excuse me. Your blood level is going to go up right away, and then over the course of another 24 hours, that mainly the free T3 level of the thyroid is going to start to taper off. Where the TSH and the FSH are sort of the same thing. Those are not going to change too much in a 24-hour period.
Yeah. No. Exactly. We do a different type of, we've been doing thyroid as well as the hormone replacement for a long time, but we do a little bit different in terms of traditional thyroid. We don't do the instant release, big box pharmacies. We do more of it. I love the sustained release, compounded T4, T3, but I want to see how people are absorbing their thyroid medication. So I know there's a lot of different, practitioners say, don't take your thyroid the morning of your blood draw. I want you to take your thyroid the morning of your blood draw. Not right away, because I want to wait about 5 hours. That 4 to 6 hour window, how are you absorbing the T4 component in there, and how are you absorbing the T3 component, so then I can readjust accordingly. And then also based on their symptoms.
And the interesting thing, now granted, this isn't about HRT and not thyroid, but the interesting thing too, like you said, we prefer more sustained release, which people have their opinions about. A lot of times the sustained release comes down to dosing, right? So instant release, which is what all the commercially available ones at the big box pharmacies are. Those are all instant release. And they have a little bit more of an aggressive response to the numbers, right? They're going to lower your TSH more. They're going to elevate your free T3 more.
Or you mean the free T4? Because most of them are only T4.
Like if you're using, Cytomel or levothyronine or something like that.
You mean an instant release Cytomel?
Well, Cytomel by nature is instant release. So those are going to have.
I never use Cytomel. You use Cytomel?
Oh, no. Oh. I have a few that request it. They request instant release. I'm not thrilled by those ideas because of that instant release nature. That's where people get a little nervous when it comes to thyroid.
It's hard on your heart. It's hard on your anxiety. Yeah. It's out of your system, fairly quickly. That it's kind of like by the end of the day, what's the point?
From a timing perspective, it'll raise your free T3 very quickly, and then it drops off really quickly. So the timing of when they took their medication to when they did their blood test matters a lot in those situations.
Very much.
HRT, it's sort of, now I was listening to a webinar about specifically for practitioners about rhythmic dosing, and one of the practitioners there, I thought she was very sharp, and she was talking about that she doesn't do testing. She waits at least 4 hours for rhythmic dosing specifically, 4 hours after application before testing.
You mean for hormones?
For rhythmic dosing.
For the estrogen.
So I thought that was interesting that she either no hormones, her patients are advised to do no testing or a minimum of 4 hours before they do testing.
So no hormones, then test, or a minimum of 4 hours so you don't get a false elevation. So that makes sense.
Yeah. Because, and I think the rationale there, it wasn't clear, but because you're using such a higher dosage amount with rhythmic dosing that if you did it earlier than that, or like you said, put your cream on and go right to the lab, you're going to get a very, potentially a very falsely elevated number that's going to skew. But because the dosing is so much higher, especially even from the night before, you're still going to have a reasonable blood level there because of what rhythmic dosing actually is. You're going to be able to see a number, in the hundreds, right? On static dosing, you don't want to see a number in the hundreds.
No. And if you did let's say you put your static dosing, your biased cream on at 10 o'clock at night before you went to bed, and if you didn't put it on the next morning and just went to the lab, it would be really low.
Yeah.
Just because it's out of your system by then. It's just, the hormones are great, but they just don't have a great longevity in the body, so it would be low. Then you wouldn't really know how to adjust it. So let's say somebody put it on and they did their blood test, like Lisa's talking about 5 hours later, and the estradiol levels at 30, or even at 22, and they'll know, oh, that's pretty low. And they're feeling it too because of the way that they're describing their symptoms. Then oh, we could raise up that dose. So there is, so that's where it's really more about absorbency for me to see, because some people absorb things really easy and some people don't. I find like men, just maybe because their skin is a little thicker, they tend to absorb.
Maybe more body hair, maybe.
Yeah, exactly. Mm-hmm. So they may not absorb as easily. So sometimes for men with the testosterone, I'll put a little DMSO in there. Women, I've never really had to do that. Kind of depends on the female, but everybody absorbs things differently.
Yeah. Well, like I said, there's no, even after doing this as long as we have, there's really no, except for the rhythmic dosing. Rhythmic dosing, day 12 or 10 to 12, 18 to 21, those I think are good ranges. If you're doing a static dose, maybe what about your thoughts of the patch? Because, everyone's talking about the patch these days. When would you have them go right when they put a patch on, or would that still confound what we're already alluding to? Or would you wait when they're getting ready to put on a new patch?
It kind of does both, because when I've had them test it right when they applied their new patch, it's a little high.
Yeah.
And then when I've had them
so when
test
when you say a little high, what
over 100.
Yeah, right.
Mm-hmm.
Yeah.
Well over 100. And then when I have them test it, about a couple days later when they're getting ready to apply the next patch, it's a little low. Yeah. So even though it's supposed to stay static, that level of hormone coming out in the system is supposed to stay even.
Right.
You do see that from, higher when you put on the patch to when it's time to change the new one, which makes sense, right? But at the same time, that's not, granted static dosing isn't exactly natural either. It's because natural would be the rhythmic dosing because it's recreating that ovarian cycle. But still, you don't want the hormones kind of moving around when you really want to keep them static.
Yeah, and not even knowing exactly what they're actually doing with no actual framework to those numbers rising and falling. What about trochees? What have you seen with trochees? I've seen a few. We know I don't usually prescribe trochees, but I've seen them from other people, and they can also seem to have some pretty high numbers. I can see why a practitioner would want to use a trochee because it raises the number. But what have you seen with trochees?
I like trochees. I have a few patients on trochees that do really well on that. What I find is if you don't, even though you're letting it sit inside your cheek and like I'm letting it absorb.
I'm not going to swallow.
Yeah, exactly. I'm not going to, but it still ends up going down into the digestion. So I do find that you still have this sort of absorbency that's going digestive rather than doing the sublingual or the transdermal like you're doing with the cream. I do notice that the trochees tend to raise the blood levels quite a bit more than the transdermal cream. So you just have to be careful with that. But I haven't seen, at least, just in my patient population that are doing trochees, I haven't seen anything with the liver enzymes going up, where I used to see that with more like, this is old school, like, Prem-Pro and, Premarin. Nobody ever takes that oral stuff anymore, that Premarin and the oral estradiol. I would sometimes see some of the liver enzymes come up just because that's really hard for the liver to detox on there. But with the trochees, I haven't seen that.
Yeah.
I mean, not to say that it doesn't, but I just
like you said, you put it in your mouth. It's supposed to go through the mucous membrane. Okay, so a good idea in theory, but you're still going to end up swallowing a lot of that. So you're kind of getting some dual absorption through the mucous membrane and through the what they call the first pass of the liver. You're going to end up swallowing probably a good majority of it, to be honest. I just thought I was just curious about that. So that probably we just made it more confusing than what her question really is, because there's really not. Maybe with her 4 to 6 hour window, maybe that would be a reasonable time to do it across the board, 4 to 6 hours. Especially if you're doing a patch, a trochee, or static dosing. That seems like it would be. You do it in the morning, 6 to 7. Go to the lab around noon. That seems like a reasonable time to do it.
Some women, they'll even set their alarm clocks really early because they want to get to the lab before work, or get in there for the first draw. Or if they're doing fasting, they might be combining some fasting blood work with their hormone blood work, so they might put it on a little bit earlier. Sure. But I do try to really sort of push that 4 to 6 hours later.
Yeah. So anything else about Lisa's question, or are we done with this one for now?
I think this was great.
Yeah, I think this is a good one. So if you haven't been here before, we have a comment section down below. Everyone's familiar with that with YouTube. Feel free to ask us any questions. If you don't feel comfortable putting your question out in the public, then you can go to our website, progressionhealth.com. We have an Ask the Doctor tab at the top. You can just submit your question there. When you give us nice compliments, how much you love our podcast, it really helps to get your question read on the show. We do have a new newsletter, so we're excited about that. You can also find that on the website. Just enter your email and it'll show up in your inbox. So any last final comments or suggestions or anything about Lisa's question?
Nope, it's good. I keep kicking the dog down here. But he's passed out.
Yeah. Until next time, I'm Dr. Maki.
I'm Dr. Valorie.
Take care. Bye-bye.